So we are here for the Facilitated Integrated Care Success with Co-Occurring Disorders, a case study. Dr. David Ferruolo will be presenting. I'll introduce him in a moment, but just a few housekeeping activities first. As you all know, we have our roster that we need to sign if you want any continuing education credits. So I'm just going to start passing it around the room. Please sign in. So for continuing ed, the sign-in sheet's going around. You'll see a SurveyMonkey evaluation that will be emailed to you. Also on the conference registration site. They're asking for it to be please completed within 2 weeks, and a certificate will be mailed to you in about a month. For those of you that want any continuing medical education or nursing contact hours, a slightly different process. Process is outlined on this yellow handout. You can find additional yellow handouts by the door. Same thing, it's a SurveyMonkey link. We're trying to get you to complete this by the end of the week if possible. If you go a little longer, that's okay. And we will email you a certificate as well. There are no conflicts of interest to disclose. And lastly, this session is being recorded. So anybody in this corner right here, there is a microphone right above your head. If you could all just help us try to mitigate any noise as much as possible, we'd appreciate that. So for the bio, for Dr. Ferruolo, he works full-time in an integrative primary care and behavioral health environment, focusing primarily on patients with co-occurring disorders and working side-by-side with medical clinicians. Dr. Ferruolo is duly licensed as both an LICSW and an MLADC, and is a leading field supervisor to MSWs and OT students for the HRSA Integrated Care Grant at UNH. Dr. Ferruolo was integral in bringing together primary care and behavioral health clinicians to begin operating as one integrated care team that has proven to be a model for success in this environment. Without further ado, I'd like to introduce you to Dr. Dave Ferruolo.
Contain your enthusiasm. I know it's the end of the week, end of the day. Would it be too much trouble to ask everyone to move up to all these empty seats? If you're willing to move, come up closer. We can't talk about collaborative, integrative health if we're all sitting in our own little silos in the back of the room. Plus, you won't be able to heckle me from back there because they'll just ignore you. Then we can shut this door because
thank you.
That's really annoying out there too. So they're recording, and I was in this room earlier and everyone's cell phone was going off. So if we could just check our cell phones so they don't go off loudly. Because they vibrate your back. That's up to you. So welcome. My name is Dave. I work at Health First Family Care in Laconia, and we have 2 offices in Laconia and in Franklin. We service the Lakes region and the Twin Rivers area. We service about a population of about 90,000. We have about 8,000 patients in our combined practices. Today we're going to be talking about facilitated integrated care success. And it's really, the gist of this has changed since the first draft that I sent in because they wanted it to be in this room and everything. So, it kind of morphed. So it's more about the process of how we went from being an agency with multiple disciplines co-located to actually working as a team. And the process, as me being one of the only behavioral health people there at first, starting as an intern, and then here 6 years later, where we're at now. So it's kind of a anthology of of experiences through my first hand, through what we do on the floor, what happened on the floor, and what we did in the hallways and in the rooms to establish the kind of care that we deliver to our patients now. So what I'm going to be talking about isn't theoretical or what I think we should be doing, it's actually what we are doing, which is kind of cool. Let me see if I can figure out this thing. There. So, really quick, there's not 70 to 100 people in here, which was originally proposed. So I kind of want to go around, I want to get a feel for who's in the audience, because as part of an integrated collaborative care model, I'm going to make this an integrated collaborative care presentation. So I will be using people for their, I won't use the word using, I will be asking if you are willing to please participate in this presentation by using your acquired knowledge base to help me through this. All right, so just really quick, your name, what your discipline is, training, where you work, really kind of quick. I don't want to use up too much time, so where do we want to start? How about over here?
Kenton Taylor, I'm project manager at IDN3.
Okay, manager of IDN3?
Yes, integration project manager.
I'm Julia, I'm from Greater National Health Center, and I'm coordinator of intake, coordinator of CPI, and therapy.
Okay, thank you.
My name is Jean Champigny, you can call me Reggie. I am a becoming LADC, hope to be soon, LCMHC, working in an outpatient substance misuse facility.
Cool, thank you.
Alicia Page, I'm an AmeriCorps Community Resource Corps member, and I'm connected with the Fair Transitions team with IDN6.
Cool, thank you.
My name is Kaylee McNulty. I'm a physician assistant. I work at Lincoln Healthcare. I kind of have 3 hats there. I'm a family practice provider. I'm also a behavioral health provider part-time. And we also have an integrated program at Greater National Mental Health, and I'm the internal medicine provider there.
Nice.
Program and internet contact assistance.
Thank you.
And I'm Lisa IDN, Region 6, Community Navigator, and that's the LADC for Vision Management Health. I'm Aiden Bard, Region 6, PNS Therapy.
I'm Cynthia Twombly, with West Central Behavioral Health, BPU operations, I'm licensed mental health counselor, and working with IDN Region 1 integrated care.
I'm April, case manager at Alpha.
Bill Gunn, clinical lead with IDN6.
I'm Polly Morris, I work at Harbor Homes, which is a facilitating organization for the recovery centers around the state.
Dave Carroll, coordinator of the case management team at the mental health side of Greater National.
Julie Barrett, and State of Rochester, doing continual care.
And I'm April Mottram, program manager, IDN program manager for Region 7.
Rick Silverberg, I'm an LICSW, and I'm the executive director of Health First Family Care, and also the treasurer for IDN5.
Hi, I'm Scott Meyer. I'm happily semi-retired after 3 decades of teaching undergrad social work at Plymouth State, and I consult in home health and hospice and supervise folks for their license and training and programming now and traffic management. Busy boy, but liking the different pace.
I'm Melanie Lyons. I work for Northern Correctional Facilities based in Berlin as a LICSW.
My name is Shelley Nicholson. I am a psychiatric social worker for the Department of Correction in the North Country facility.
My name is Jessica Stiegler. I'm an LMHC and I'm the advanced case manager for all.
Here we are.
Peter Mason, family doctor for the medical director for the
Thank you.
I'm Asha Geiger. I'm a RN and hopefully retired.
Hopefully retired.
Melissa Udis. I'm an LICSW. I'm an integrated behavioral health counselor at primary care for Wentworth Douglas.
I'm Charlene Gerard. I'm an occupational therapist with the Rockingham Visiting Nurses.
I'm Dawn Maries, I'm the Executive Director of the Youth Council of International.
Hi, I'm Linda Brewer, and I work with the State of New Hampshire Employee Assistance Program, and I also have a private practice with Meredith, New Hampshire, and LICSW.
Cool, thank you. Did I forget anyone?
I'm Nancy Frank, the CEO of North Country Health Consortium, which is the lead for Region 7.
Okay, thank you. So good, now I know who everybody is and who I can call on when I need assistance. Okay, that's what this is all about, right? All right.
Sound guy.
So just a little bit about health first, and that's where I work, and Rick back there, the executive director, is my boss, so I'm not nervous at all about standing up here and talking in front of my executive director. So Health First is an FQHC, a federally qualified health center, and we're a patient-centered medical home practice. We have integrated behavioral health and primary care, and also, if you can see the little sign there, we have primary care, we have pediatrics, we have behavioral health, we also have dietitians, we have case managers, we have care coordinators, we have patient navigators, of course we have nurses, we have occupational therapy as interns. Our scope of practice won't allow us to hire them right now, but we're working on that. What else? Am I missing anyone? So we have the big practice, 8,000 people, like I said, a little over 8,000 people, and a majority of our patients have co-occurring medical, mental health, and substance use disorders. Okay, I don't know what that did. So this is our agenda for this presentation. Why integrated care? What is it? Some case study successes will be thrown in here, and I'll be asking for case study successes from our participants here, and also some case study failures where there were breakdowns where patients didn't get the care they needed, and if we had integrative care, like where would it have gone? I'll go through basically my story, which I titled Beginnings, Transitions, and then Progressions, like where we are now and where we're going in the future. So, integrated care. So let's talk about a typical story of patient care. I would say prior to integrative care model, but it sounds like from what I've heard today and most of the presentations and yesterday and from people that I've talked to that integrative care is more of a suggestion or a concept and not actually a practice. I have talked to some people that are practicing really phenomenal integrative care, but for the most part, it's more co-located or a suggested thing rather than practice. So let's talk about the typical story of patient care. So who has a private practice, who has something they want to share about trying to collaborate with PT, OT, primary care, psych, specialists? Anyone? See, that's why we need 70 people in here, I guess. So, all right, so let's just pick a case scenario. So you're in private practice and you have a little office somewhere in a town, and your patient comes in and they're suffering from depression and anxiety. Maybe they were in a car accident a couple years ago and their anxiety really kind of started then, and there's some other stuff going on but you're not quite sure. You do an assessment. They meet the criteria for depression and anxiety. Maybe they're drinking a little too much because it helps them sleep at night. What else we got in there? We'll just go with that. Just your preliminary. Like, what would you in private practice do with that patient right off the bat?
Coming out of private practice, in most cases, anyone with any sort of comorbid substance use and psychiatric concern period would end up getting referred out to psych somewhere.
Referred out to psych. Okay, what does that look like?
Give them a paper.
Give them a paper.
Tell them where.
There's the door. Give them some lists. Go on Psychology Today and maybe look.
Unless you have people that you are regularly working with, ARNTs that are prescribing, primary cares that you collaborate with. I'm in a small community, so we have that. We're lucky to have that. So
Okay.
it's a phone call right then and there. And
So it's a phone call, so you pick up a phone and then you send the person there, they get scheduled in, and then what happens?
And then we're collaborating here, that person's
Okay.
going.
So if they prescribe meds, you know, and you go back and forth,
Yeah.
okay, awesome, that's great, that's good. Yes?
I think they should call somebody from Peer Recovery Support Services and they could come meet with them right there and talk about their experience, maybe know some of the resources in town and connect them with some of the peer support services readily available.
Okay. So, referrals out. Okay. Referrals out, phone calls, referrals out. Okay, so let's talk about what possibly could happen at Health First, where I work. So a person comes in, same type of thing. And now I'm thinking, okay, so car accident, and anxiety started at the car accident. I wonder what else is going on. I might do a deeper psychosocial, and then I might think, okay, so who's your primary care? Maybe the person hasn't seen anyone for a while. So I open up the door, and I go like this, and I say, hey, Russell, can you come in here for a minute? But Russell's a nurse practitioner, and he comes in, he sits with me, we talk about it, and then Russell sets up an appointment right then and there while we're sitting in that room with that patient. And if he has a no-show or if he has time in his schedule, he might take that patient out, do vitals, get labs, and test for stuff, like what's going on. He might try to get he might have his medical assistant get records from the ER or his other primary care doctor, or we can coordinate all that literally right there on the spot within 10 or 15 minutes, and then we have a good bird's eye view of what's been happening with this person, and we already have a care managed plan for that person that they're sitting there involved with. And of course, we don't do to them, we ask them, of course, because what was the last one we were at about, collaborating with the patient and making the patient part of that team. So we do that really well at Health First, and that's not what we do, it's really how we do it. That's the daily mode where I work. And if Russell needs something, or if one of the other PAs, or we don't have PAs, one of the other NPs, or the doctors need something, they'll just come right to my office, and they'll knock on the door, and I'll go right in the room with them, and we will figure stuff out right there, right on the spot. Yes?
How many NPs and doctors are in your office?
We have 2 doctors now. We just hired a new medical director. We just hired a new nurse practitioner this week. So we have 1, 2, 3, 4, 5, 6 nurse practitioners.
6.5.
Right.
Specialized pediatrics.
I always forget about Catherine. We have a pediatric DNP from Dartmouth that comes down 2 days a week. And we have 4 mental health clinicians, including Rick. He doesn't practice actively, but so we have 5 fully licensed mental health clinicians plus a full cadre of students at any given point in time.
Is this like your 2 facilities or just that?
That's between both facilities. So at any given time, there's a minimum of a medical and behavioral health provider in the building at all times. And I'll go through the whole thing. I'm going to finish my whole thing now, and you just won't need this presentation. So, why integrated care? And I have a habit, once you get me talking, I don't stop, so we'll be here until 8 o'clock tonight. We'll be ordering pizzas and free bacon from the place down the street. Why integrative care? So, depression is the #1 diagnosis in primary care. 50 to 70% of people that show up at primary care have a clinical diagnosis of depression or anxiety. PCPs are the go-tos. The primary care physicians, the doctors, the NPs, the PAs, they're the people that are seeing people come in with, hey, I sprained my ankle, but hey, I'm really anxious and depressed also, or I'm drinking a whole heck of a lot because of my prior back injury, and oh yeah, my blood sugar is like 350 today. So they're seeing this. So what are they doing with it? 75% of patients who present with depression and anxiety at a primary care facility who get treated for it by their primary care physician, typically 75% show no improvement, and less than 20% of them will actually get referred out or go to counseling. So, as the research says, inadequate and sporadic. So Health First, here's a snapshot of Health First, a community a community health center, 8,000 patients, and 4,800 diagnosed with some kind of mental illness. And there's the stats, if you can see them. Depression and anxiety, almost 2,000 patients each. I don't know which one of these are co-occurring, but these are individual diagnoses that we mined out of our medical records. So you can see, like, substance use disorders is only about 3.5, but 24% have depression, 24% have anxiety. So the primary care providers are the first people who see these. So in our agency, it's really nice because they can just come to our office, knock on the door, and they can get them in, usually that day, at least to see us for 5 or 6 minutes, you know, somebody, an intern, somebody. So integrative care, there's over 80 published clinical studies according to this research that I found. And collaborative teams lead to, basically the bottom line is they lead to better patient outcomes, they lead to better patient success. It also leads to a better work environment, and we'll get into that in a minute. So I'm going to spare the end of the day. Let's do little groups and figure out our collaborative definition of what collaborative care is, and we'll just go right to the research. So, according to Grazier, the connection of behavioral health and medical services interwoven to produce a tightly integrated on-site care team who works together to deliver a comprehensive service to their patients. Okay. I'd like to say with their patients, not to their patients. We're going to do things to them. We want to incorporate them as part of that team. I just came from the language one, you know, so I'm going to be mindful of my predecessors and hopefully use what they've already said to help me. So definitions. Dickinson, who's a medical doctor, this is his definition: care rendered by a practice team of primary care and behavioral health providers working together with patients and families using a systematic, cost-effective approach to provide patient-centered care. So sometimes the financial people at our organization don't see worth in my ability to walk into the room with the provider with a patient who is crying and has severe anxiety and spend 5 minutes with them and leave. The financial people might not see the benefit of when I open the door and say, hey Russell, can you come in here for a minute? I really want you to assess this for me. And he comes in for 5 minutes, taking time out of his clinical schedule to come see my patient, or our patient now. And so they don't see the value in that, but the patients see the value in it, and the team sees the value in it because it develops trust. It develops a comfort level that we're really working together for that person who's there. And from what I've seen, from what I've been told, the patients really appreciate the fact that they can get this type and this level of care right on the spot without going, wait, you're not going to send me somewhere? It's going to take me 6 weeks to get an assessment at that other organization. No, we're going to do it right now. And if I have time, we're going to fit you in the schedule somewhere today if we can. If not, within the next couple of days. We actually have spots built into my schedule for those type of acute visits. And we practice a behavioral health schedule that incorporates 20, 40, and, well, the 60-minute visits, but they're really 50. But 20 minutes, 40 minutes, and 50-minute visits, so that my schedule is always varied, so I always have time in between to assist the providers or the nurses or the MAs or whoever I need to assist. Sometimes it's the front desk people. So it's really kind of a dynamic, I call it the floor, on the floor, we're always on the floor. So some of the barriers, so this is funny, I actually developed this whole presentation and then I went back when they said, hey, we want to use it as part of the IDN track. So I went back and then read all the research that was on that first page, and it was almost, it synced up perfectly. So what I lived through when starting at Health First for the last 6 years is everything that's in the literature, but I didn't read the literature back then, I just did it, and it just happened. So it's this, what's in the literature is actually a natural progression of going from, let's think about collaborative care, to co-location, to integrated teams. So some of the barriers to integrative care, of course, silos, Trust and rapport, socialization, understanding and respect. Whoops, going the wrong way. Keep going. Segmented practices, everyone kind of practicing on their own. And a lack of a cultural or inadequate culture indoctrinations too with the team approach. So, when I first started at Health First, maybe Rick should leave the room for this part. So when I first started at Health First, I was an intern. And talk about silos. The behavioral health staff was, well, the behavioral health person, there was one LICSW working in the building, and she was on that side. Then we have this big massive hallway down the middle with 2 other hallways, and then there's pods of providers, of medical providers and their teams on the other side. So, medical on that side, behavioral on that side. And what my supervisor told me when I started as an intern was, yeah, we just stay on the side of the building. Okay, why? It's just the way it is. So we did our thing, they did their thing, and referrals were suggestions. They really were. We might as well have been in separate buildings. So, trust and rapport. How many MSWs, LICSWs in the crowd? So, you know, they do a good job teaching us, like, you know, that holistic approach, and like medications is like the last place to go, right? So I'm coming in there going, well, nobody needs medication. We'll just do some CBT. We'll do some, you know, some self-care stuff. We'll teach them some stuff, you know. I'm going to give them stuff and stuff and stuff, and then they're going to be fine. And, you know, I quickly realized that that wasn't the case, but it was a big learning curve for me. But when I first got there, my supervisor, basically, this was it. Their answer is just medications. Let's just give them more SSRIs. Let's give them benzos. And we called one guy Dr. Benzo. And so, like, I was like, I don't know any of this stuff. I'm a social worker. I have an MSW. I'm an intern. I'm a first-year intern. I know nothing. Okay, what do we do? So I'm just going what she says. Like, they just want to give people meds. And the providers were like, yeah, you can go talk to those people, but it's probably not going to help here. Here, take your medications. So again, I do my thing, you do your thing. There was no coordination, there was no communication, and you know, referrals are more like, you can go talk to them if you want. It was like, yeah, your leg's broken, you can go see the doctor if you want. Okay, so socialization. Actually, these are quotes that I'm putting up here. So I didn't just make this stuff up. So one of the medical providers back then was basically said that to me. She never says hello. I don't even know who she is. I know nothing about her. And of course, my supervisor was like, you know, he's always so dismissive and rude. And I'm thinking, I wonder why. Okay, now we're into the biggies. Understanding and respect. So counselors were really seen as caseworkers, resource managers. Oh, you might need to file for SDI, go see the social worker. You need to go to unemployment, go see the social worker. It was, you know, the social worker was the person that helped you get resources, connected you with, you know, the TANF, the SSI, the SSDI, whatever resources you might need, help you file for unemployment, help you file for housing, give you a list of food pantries, find you a ride. That's what the providers thought our job was. So we were just support. There was definitely a huge lack of knowledge of other disciplines. I saw that right away when I was talking to everyone in the building. And there was a big lack of the biopsychosocial model at Health First. The doctors were really focused on the medical model. You know, you got a cut, let's stitch it. You know, and the behavioral health people were all on the other side, going, well, we don't need meds. We can just do CBT, and everyone will be happy. And of course that works, but we also know that the research says that CBT does not work to up to 40% of the people that engage in it. They have to be cognitively available to engage in something that's cognitive, right? So we work at an FQHC. What does that mean? That means that a lot of our clients are on Medicaid, the lower stratas, lower income, right? They have multiple social determinants, right? They don't have the ability to sit there and use their prefrontal cortex and think through some reality testing. they just don't have that. So doctors being really frustrated, the NPs and the PAs being really frustrated, benzos worked. Okay, so we had people that had, you know, like 90 Ativan and for a month. And they were just in the thing, just every month, just refill. Yeah, but they never sent them to counseling. So, segmented practice, same type, but we're just going down the same road here. I'm not going to ask Rick whether he agrees or not, but what I'm doing is I'm pointing out. So, I am pointing out what it was like. But I also want to point out that when I started, nobody else was doing this. Well, I take that back because there were some people that were doing this. But it was pretty novel to have licensed mental health people sitting in the same place with providers being able to look down the hallway and there's their office. It was pretty novel. When I went back to my field classes at UNH, my MSW course, they were like, what are you doing? Now they have, you know, a multi-million-dollar grant to send people to learn what 6 years ago they were going, what? So we've come a long way in 6 years. But Health First really, here I'm going to suck up to Rick now, really was because Rick came from a social work background, and when he started Health First, he saw the value in having behavioral health or counselors in the primary care situation, just even if it was for acute or for, I think originally he got away with being able to bill for those acute 6 visits before we referred out. But then with the Parity Acts and all the different things that came around with insurance, we were able to start billing for mental health. And since we were already poised for that way, we were able to hire full-time mental health clinicians, behavioral health clinicians in our practice. So I wouldn't even be talking about this if there wasn't somebody there working in that environment anyway. It might have been a little dysfunctional, but it was still ahead of its time. So, so the research says that there has to be a champion, okay? So there has to be some kind of influencer. And on the floor at the 2 buildings, there really wasn't. Our executive director, Rick, was definitely the champion and the influencer of the behavioral health integrated model with the primary care. However, he's the executive director. He's not on the floor every day. He's not seeing clients. He's not working around. He didn't have that influence to be on the floor to do that. So we didn't really have that influence to bring everyone together. So there was also no onboarding. There was no cultural immersion. Everyone did their own thing. When you get hired as, as front staff, you get hired as front staff. If you were a nurse, you get hired as a nurse. If you're an MA, you get hired as an MA. And working together was not part of that indoctrination when I first started 6 years ago. So the first thing that I realized was, well, let me just back up a little bit. So I was at Health First for a couple of months as a first-year social work intern, and my supervisor quit because she saw that job as her stepping stone to licensure, and then she was off to greener pastures. And apparently the people before her had done the same thing, and a lot of people that I talked to at UNH in Petty Hall, where the social work social work program is, pretty much had the same type of thing. You go to work for an agency, you get your feet wet, you find a supervisor, you get your license, boom, and then you're out of there, right? You're out of there. You don't want to do that. You want to go in private practice. Everyone wants to go in private practice. So that was what my culture indoctrination was. I started working there. My supervisor left, and I was there by myself, and I was just there as an intern, and I didn't know anyone. I didn't know anything, and I said to myself, this is going to be really boring. So I said, I gotta go talk to these people because I'm in this building all by myself. I'm an intern. I don't have patients. I don't have anything to do. I'm reading my books. I'm ahead on my work. So I developed a plan of action. Now this plan of action didn't develop when I was an intern. This developed as time went by, right? But I did know a couple of things. I did know that I wanted to start working with these people because I had something to teach me. I was a student and I wanted to learn. And I also knew that this was going to be a really boring internship if I had to sit on the other side of the building, literally in a row of offices that were empty all by myself for 6 months. And probably noticed I'm not that kind of person. So this was my action plan that slowly developed over several years. So Granger says that health service delivery research has identified the importance of a strong, pervasive leadership, a champion for the cause of integration. Hey, I'm the social worker, so I just started becoming social. I just started talking to people. I just started making friends. I wasn't going into work. I wasn't going in to collaborate about patients. I just started making friends. I started introducing myself to people. I started being a social worker. I started being interested in people and not what they do, but who they are. And from that, all of these conversations started springing up, right? And so one of the NPs, her daughters were in the school that I graduated from, and then somebody else practiced the same karate I did, and somebody else was on the same did the same skiing that I did, and so we developed all these friendships, and friendships was the first, and I think the absolute most important thing in an integrated care agency that wants to practice this collaborative care is the level of communication and friendship that you have with your coworkers. So, making friends first. So my first integrated success story. Okay, I'm doing good. Probably not. So my first integrated success story. I'm an intern, a first-year MSW intern. So if anyone doesn't know about the MSW program, we don't learn anything until the second year, but we're put in placement day 1 of the program. So we start school and we start placement at the same time. So I was a marine contractor. So I went from off my barge to in the office at Health First. And I'm like, okay, what am I doing here? So I don't have a supervisor. Rick did the best he could, but he's the executive director. He doesn't have time to mentor an intern, but he had someone hired for that, but she quit. So I get this patient, and she's semi-catatonic when she's come in. She's freaking out. She's thinking that she's losing her mind. She thinks that she's going crazy. I'm going to use all those bad words because those are her words. She's a single mother of 2 kids. She thinks she's going to get evicted. She can't hold down a job. And I'm like, what is going on with this person? And then she's like, oh, I'm on all these medications. So I don't know anything about medications, but I just looked them up on the internet. And when I looked them up on the internet, basically everything she said was a side effect of the Seroquel and the Abilify, because she was diagnosed with bipolar disorder by an independent nurse practitioner somewhere. And I said, oh, did anyone ever assess? And she said, no, I went in there and I was having some issues, and she had a significant trauma past, which she never talked about with the nurse practitioner. I just get mad a lot. You're bipolar, here's Seroquel. And that didn't work, so let's put some more Abilify on top of that. And then she had a list of mood stabilizers and antipsychotics. When she came in, she was at the end of her rope, semi-suicidal. The only thing holding her together was her 2 little baby daughters. And so I walked into the nurse practitioner's office and I said, this is what I have. And she's on all these meds. And she looked at me and she said, well, I trust your opinion, Dave. I've gotten to know you and I think you know what you're talking about. So what do you think? And I said, I don't know if she's bipolar. I just met her. She hasn't seen this nurse practitioner for a couple of years, but she's been on all these medications. So I worked together with that nurse practitioner to get her to Health First as a patient. And we took her off the medications, and literally within 1 week she came back a completely different person. A completely different human being, okay? Did we diagnose her with bipolar disorder? Maybe, but she had a significant trauma past. So all those behaviors that she developed as her coping mechanisms kind of were in her adult life, so I worked with her my entire internship. So I'd like to say that 6 years later, she is just applied to go to UNH into the NP program. So miraculous, right? So that was the first thing. That was the first time that I worked with a provider and had success. And I was like, okay, there's something to this. I have to work with these people. These people know a lot of stuff. I don't know anything. So, wait, I don't know where my clicker is. So that led me to the action plan of understanding and respect. Like, I needed to know what everyone in that building did. I really did. I had no clue. You know, RN, MA, DO, MD, PA, NP, blah, blah, blah. The list goes on and on, right? And that's just ones that I came up off the top of my head. So I'm sure that those of you that are in the medical field and work in that can probably come up with a list that, you know, that's 5 times that. So does everybody know what all these stand for? Okay, we have a couple of ringers in the audience, so you know, the doctors and the PAs, you know, you don't have to speak up until I say. So does anyone know what the difference between an MD and a DO is?
Doctor of Osteopathy.
Okay, what does that mean?
I believe they have the ability, technically, almost like a chiropractor, to do manipulations of the spine, and that's as much as I do now.
Okay. I didn't even know that when I started, but we had medical doctor and a DO, and I didn't know the difference between them. So, anybody? Difference between DO and an MD?
They're trained in holistic medicine.
Yes. Okay. DOs are trained more under a frame of holistic medicine and have the ability to do manipulation. So, what's the biggest difference in the primary care setting as a family physician? I don't know, I call them both doctors, right? Their job description was the same, except that our DO did take manipulation patients because he was very comfortable with that. And also some NDs don't have the ability, I'm not going to go into all this stuff, but this is just certain little things. Some medical doctors, if they're internists, they can't see children under 18, I believe, sir? Right?
16.
12? All right, we have 2 MDs, they're both internists, and they don't want to see kids under 18, so they send them to the nurse practitioners. But our DO saw everyone. So psychiatrists, psychologists, what's the difference there? It seems an easy differentiation if you work in the business, but one's a doctor. One is a doctor, okay? And one has a doctorate in psychology or a psych. So, what's the difference between a PA? Does anyone know what PA is? Besides the PA in the room? Physician's assistant, right? And an NP, or an advanced practice registered nurse. What's the difference between a PA and an NP? Very little, except nurse practitioners are independent practitioners, but that's changing. Okay, laws are sweeping. PAs and NPs will both be at the doctorate level and have independent privileges soon. So, but really, there's not much of a difference. What's the other? PAs have to work under a doctor. So a medical doctor has to sign their charts or whatever. They cannot work independently. So, not going to go through all these, but these are just some of the things that I had to learn. What was the difference between all these things? And this is my favorite one right there. I just learned this one myself. What is that? You can't say it. Okay, you can say it.
Behavioral health.
Behavioral health occupational therapist. You didn't know that existed? Well, if Abby was here, I'd introduce you to her. She's my intern from UNH as part of that nurture grant. So, learning about what everyone can do, what their roles are, was something that I had to do for myself, and also something that I had to do with the providers. They didn't know me. They didn't know anything about, on the other side here, what's an LICSW, MSW, BSW, MLADC, LADC, CRSW, like blah, 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 blah. What is all this stuff? They necessarily really didn't care. They really didn't. When I first started there, they didn't really care. It wasn't something that they did. You were on that side of the building, I'm over here, we do this stuff, you do that stuff. And they didn't really, I don't think they did not respect me, I think they liked me, they just didn't see me as useful in their medical model. So, as much as I had to learn about what everyone did, I slowly, using my Jedi Master social work skills and motivational interviewing techniques, taught them very subtly what I was capable of doing and what I could do for them to help their patients, our patients. So, understanding and rapport. So, this opened the door to more patient discussions. The PCPs really started to come and engage with me more. I started to get more referrals, I started to get more patients, and I believe this was my first year post, after I graduated, so I wasn't licensed yet, I was just Rich nodding his head yes. So once this started, I decided that I would take on a bigger role, but I was going to do it backdoor. I was going to create a policy that was going to come down from management, and then we're all going to have a discussion about it. So, whoops, where did we go? I wrote a benzodiazepine policy. So what I did is I went through all the medical research, and I came up with the indications for what benzodiazepines were supposed to be used for and the length of time, and all the the addictive qualities and everything, and then how we could effectively use benzodiazepines as they're supposed to be used, with the indication that it's supposed to be used, and get away from them being a lifestyle medication, which is what a lot of our patients were on. I mean, 90 Xanax, and I think she had PRN Klonopin 30 on top of that every month, and that had been a script in the EMR that was just pressed every month by the so you see where we're getting at. So we went through, and me and one of the nurses went through and kind of did a lot of this research and then presented it to Rick, and he said, wow, this is a great idea. The providers were like, what? Okay, let's do it. So all of a sudden, behavioral health productivity went way up, which meant the bean counter in the other office started to get happy, because all of a sudden I was bringing in money because I created this policy. So it worked. It worked. But also what it did was it really brought the behavioral health side and the primary care side together, working as a team on one thing. Because I didn't just write this thing, give it to Rick, and he didn't dictate it down. Okay, it was very Jedi. We did this, and we went to the providers, and I asked them their opinion. What do you think? How long do you think people should be on benzodiazepines? Well, what about this person? I found this person that's been on. Oh, I don't know about that person. Let's look at it. Once I get them looking at their own charts, at their own medications, some of them didn't even know that these people were on these medications because they inherited the patient. And really, sometimes it just slipped through the cracks. So we did, basically over a 2-year period, a huge benzodiazepine taper on hundreds and hundreds of patients, to the point now where I saw the last list at the Laconia location. There was less than a dozen people on benzodiazepines, and when we prescribe them now, they all have to meet with us first. So the provider will say, okay, let's go meet with Dave, go meet with Mark, go meet with Ashley. We have several providers that can do behavioral health assessments, and we'll assess their whole biopsychosocial, and we'll go back and we'll have a discussion with the prescriber. This is what we think. Yeah, they probably need them, or no, I don't. I don't think they need them. This is coping skills, right? So in the past 3 or 4 months, with I think 3 different providers, I've done one patient collaboration each where we've actually prescribed benzodiazepines, and they were all in the case of either an overdose of a child or 2 suicides of children, of teenagers. So those parents, we decided it was the best course of action at that point in time. But it was very short. It was less than 2 months. So, and we had them in counseling the whole entire time for support. So that was like one of the first big breakthroughs at Health First. So then the real learning curve came for me. Then I started finding out that there were many things that could affect someone's mental state. They don't teach you this at Petty Hall at UNH. They don't teach you that if someone's thyroid's out, they could present as if they have a severe anxiety disorder when they don't have anxiety at all. They have a thyroid that's not working, okay? Or their diabetes is off the chart, or they have Lyme disease. So there are, medical terminology, right? There's books written about this stuff, but I lived it on the floor. So here are just some things that a few of you in the audience, you just take this for granted because it's what you do all day, okay? But for the behavioral health people in the audience, they might look at this and say, oh, I know what some of those are because my doctor did those tests on me, but what are they? What do they mean? You know? So I had to learn what all this stuff meant, why they were doing it, and then I had to conceptualize whether what the providers were doing had an effect on the person's behavioral health. And what, 7 out of 10 times it did? So, there we go. Some medical conditions that can mimic or cause anxiety or depression. And I welcome the collaboration of the medical providers in the room. If they want to add to any of this, or if there's anything up there that they think is critical for everyone to know, please just chime right in. So, at Health First, this is a big one. You know, mental health providers don't understand the effect that the body can have on the mental state, right? And vice versa. Sometimes I don't think the primary care providers, the doctors and the NPs and the PAs, really conceptualize that if someone's having severe mental issues, behavioral issues, how it can affect their medical issues also. So these are just some of the things right here. Some of the things are, there we go, next page. They don't teach you this when you go to become a mental health counselor or social worker or case manager. So building that deeper knowledge helped me help patients. It helped me build a collaborative bridge to my providers. And basically it led to a lot of good catches and patient successes. And these are just 4 that all just happened within the last 4 or 5 months. It just came to the top of my head when I was doing this. This happens almost daily on the floor at Health First, between me and Russell and me and Dr. Janeway or Dr. Abby Singh or any of the other nurse practitioners. This is a daily occurrence. When you walk through Health First, all the stuff that was in some of the other presentations about, like, you need to perch yourself and you need to insert yourself. And it's like, that's what we do. Like, that's who we are. When you come to find me, I might not be in my office because I'm probably in a room with a provider. Or you'll come to my office, you'll open the door, and me and the provider are in my office working with the patient. And it's what we do. It's hard to explain it from that point that, this is kind of different. People don't do it at this level. Like, they think about it, conceptualize it, but to have a patient come in to see me who has a co-occurring disorder. Yes, he's schizoaffective, and he also has, he suffers with an alcohol use disorder. And he came into my office and he sat down and he was all down and just like kind of really off. And I'm like, are you okay? And he looked up and his eyes were as yellow as your sweater. And I went, I will be right back. I opened the door. I went into Russell's office and I said, I think we have a problem here and I need you to come in now. And he said, okay. He walked in, he sat down, he's like, well, we have a problem. And we took vitals and shipped that person right off to the ED. Right then and right there. I don't know what I would have done if I was in private practice, if I didn't understand what jaundice was, or if I didn't understand that liver function and yellow eyes had some kind of connection, but I learned that working on the floor at Health First, and that helped me to be able to assess that immediately and know that that behavioral health visit is now going to turn into an emergency acute visit with the provider staff, which it did. He left my office and off he went. Another gentleman, this just happened 2 weeks ago. A gentleman came over, came to see me because he had been recently suffering with depression. And he didn't have any substance use issues. but he was complaining that he was forgetful. He couldn't remember things, he would lose his keys, and he's just really down, and I'm thinking, yeah, I don't think there's something else going on. And he had a lot of different aphasia, just forgetting everything. He forgot his wife's name in the morning sometimes. So, first thing I did, I walked out, I walked to the other office, I asked the doctor, I said, what do you think I should do? I'm thinking that this person has something going on with their brain. And she says, absolutely, we need to get him up to Dartmouth or something. And he wasn't our patient, so I came in, I sat down with him, I spoke about my concerns that the team thinks that there's something else going on that might not be related to depression. He's retired. He has means, he has a great family, there's nothing negative in his life. He has never suffered with depression in his life, nor he had a family history. There was something else going on, but he presented to me, to a counselor, for his depression. He didn't go to his PCP. His PCP probably would have picked that up in a millisecond and sent him off for scans. So we sent him off, haven't heard back, it's too recent. So, but he is getting the help he needs to assess for whatever's going on. Dr. Janeway thinks it was probably some kind of stroke. Two other things, Lyme disease and thyroid. We almost always screen for Lyme disease now. Anytime someone comes in and they have depression or anxiety, accompanied by joint pain or anything along those lines. So just having the behavioral health staff know a lot about the different diagnoses that can present as either depression or anxiety really opened up the door for the providers to really trust and respect that, well, behavioral health people are not just support staff. They can have a huge value in patient care, and if we work with them, the value of that patient care goes up, and patient success is more. So, talk about learning curve. So I took off my hiking boots and put on my climbing shoes, and that was time to really ascend. So, talk about what is not taught at social work school. I think we had 2 days of psychotropic medications, and a psychiatrist from up north came down and gave like a 1-hour presentation, and that was it. That was all. We had nothing else. It wasn't even talked about. Again, we used that kind of biopsychosocial model where, like CBT and mindfulness-based stress reduction will cure everything. And we don't need medications. So my views on that has changed significantly because there is a population of people that need to be on medication, and with good assessment and good clinical care, you can determine which one of those patients needs the medication and which one of the patients needs coping skills. They both need coping skills, but there are some people that biologically will need an SSRI. And if somebody has been on a benzodiazepine for the last 30 years as a lifestyle medication, we can't take them off, but we can try to titrate them down and see where the low level is. And maybe we can get them off their 90 Xanax and down to maybe a Klonopin a day, which in the harm reduction and better health, that's better for them, right? I'm going to just go through these really quickly. This is supposed to be like a full day workshop, but stuffing it into 90 minutes. So, psychotropic basics. So, antidepressants. 5 different classes. A couple of them aren't used as much anymore, but there's cyclics, there's MAOIs, SSRIs, SNRIs, and atypicals. Does everybody know what all those mean? Except you, of course. The PA's going, yeah, of course, I know what it means. So, cyclic antidepressants, they're kind of the first generation. Not typically used anymore. They have been replaced, although some of them are extremely effective for some things, including treatment-resistant depression and if somebody has some kind of co-occurring nerve pain. They've been shown to be effective with OCD, but they have a lot of side effects. The tricyclics and the tetracyclics have had a lot of different side effects, and they're very easy to overdose on. So primary care physicians in the past would be wary of. Can you people a lot of amitriptyline if they were suicidal, because not only does it can increase suicidal thinking and behaviors, but also get both those things together. So someone could take the amitriptyline to get not depressed and then become more suicidal, and then overdose on the drug you gave them to be not depressed and not suicidal. So monoamine oxidase inhibitors, MAOIs. Again, mostly replaced by the newer SSRIs and SNRIs and the atypicals, but they are still used. They are still used. You hear the ads on the don't take if you're using an AOI or whatever. So, a lot of side effects with MAOIs. But they do treat depression, anxiety, panic, social phobias, or they are indicated for treatment of, I should say. So not only do I have to learn what the stuff does in the medical field, I had to learn how to talk medical also. It's a whole new language. SSRIs, so here we go. These are things that counselors, behavioral health, really need to know and understand a lot deeper than you actually think. So, because all these different SSRIs have different chemical compositions, different mechanisms of action, and they work differently for different people. So, Russell, who's a nurse practitioner who's now going through his psych NP program, he goes, I love psych meds. He goes, because when I do diabetes, I have simple stuff. I have like 3 or 4 things I can do, and that's really it. He goes, but psych meds, it's like a big, huge jar of colored jelly beans, and you just kind of pick the different colors and you see if they work, because they don't always work. But if you can take them and you know what that color actually does, like what it really does, you can pick more intelligently based on the presentation of your patient. So Russell's a really smart guy, and I love working with him because I will say, Russell, I have this patient, and I believe they could benefit from an SSRI. Well, Dave, what's their presentation? I will say, blah, 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 this is what I'm getting, this is their history, and he will say, I think we should start with sertraline. 50 milligrams, and we'll see where it goes. All right. Or he'll say, no, we're going with Celexa. Why, Russell? Well, because the secondary mechanism of action, and he just goes on, that's way beyond my level, but I'm learning, and I can talk intelligently with him, and I read his stuff from his Psych NP program. I take it and read it, and he's got my DSM-5 to use in his psych. So talk about collaboration of care, collaboration of learning. He's teaching me way more about psych meds than I ever thought I ever would know. I can't even pronounce half these things when I got out of social work school. I still can't pronounce them, actually. SNRIs, okay, so SSRIs. I don't want to get too involved in this because this could take forever. But, so SSRIs are serotonin and norepinephrine reuptake inhibitors. SRIs are selective serotonin reuptake inhibitors, and basically depression, really depression and anxiety. And I love this about the research. We don't know why these things work or why this happens, but we know that that serotonin is responsible for this, and this. So if we can get serotonin across this, across the synapse, and we can get more serotonin, in those clefts, then people are less depressed and less anxious. So we can do that in many different ways. Okay, we can get serotonin to be more active in the brain, and plus it's neuroregenerative. So if you had some brain trauma, the SSRIs can actually enhance the production of, and the doctor left. Enhance the production of the chemical that actually promotes neurosynthesis in your brain. So taking an SSRI can actually heal damaged brains from stress or other things. So it's kind of cool. Like, who knows that? The medical staff does. I don't. I do now. So you wonder why you put someone on an SSRI. So, like, why would a field of social work be resistant to something that increases serotonin levels, which will alleviate depression. It decreases anxiety and that kind of angst that a lot of people feel, and it also is neurorestorative, neuroregenerative. I don't know why we would be opposed to that, right? And if someone then can go through a treatment with medication and counseling and then decide that they want to, cease the medication, then that's the patient's choice. But they should be given that choice, and we have an ethical obligation to know the implications of those choices. So, knowing about all this stuff from the providers, the medical providers in the building, when I can talk intelligently and accurately about the different types of medications, the different diagnoses, and how we can all come together and how we can talk about patients, the respect for behavioral health really, really increases, and their willingness to just come to you on a daily basis, it just happens. So there are the atypicals, the Wellbutrin, the Remeron, Trintellix, that's kind of a new one that's going around. Less side effects, same type of effects. Some of these things work a little differently, though. They work on different mechanisms in the brain, but basically they're the same, provide the same function of increased serotonin reuptake, well, less reuptake and more availability. So, again, here's our favorite benzodiazepine list, okay? Indicated for short term. So, catastrophic events in which disrupts homeostasis and interrupts the person's ability to cope, period. Right? So, a little bit of stress at school, or even something like losing a job, that might not be an indication for benzodiazepines. You come home, your house is burned down and everything in it is gone, that might be an indication for a short-term use of benzodiazepines. But every patient is different, so everyone must be assessed wherever they are at that time. But there's a huge risk of dependence, tolerance, withdrawal, and a high risk of abuse also. And people that have been on them for a long time sometimes can't come off them. So, and we work with I will work with the providers to find out where that tolerance level is for those people that have been on them for a long time and want to come off them. Also, there is also another reason why benzodiazepines, well, how do I phrase this? It can inhibit the therapeutic relationship because, and I wish I could remember the medical vernacular used to describe how this works, but basically, in the function of the benzodiazepine in basically shutting the door to anxiety, how I tell people is, it shuts the door to the anxiety, the noise is still out there, you just can't hear it, and then it wears off and the door opens again. So you're not taking care of the cause of it, you're just shutting the door so you can't hear it right now. But that door also shuts off a pathway to several other things, and there's research that's fairly conclusive that it shuts off the ability to create emotional connection. So some research is saying that the ability for someone to develop a therapeutic alliance and move through stages of change might not be there if you're on benzodiazepine. So just something to consider. Maybe you should go, you can go research that kind of stuff on your own and see where that is. But I thought that was very interesting. So anxiety, a lot of patients say this doesn't work when we switch them from the benzo to Bisphoron, or however you say that, because it doesn't have the same instant effect that the benzodiazepine has. And then hydroxyzine. And of course, it's just Benadryl. It's just a little stronger Benadryl, but it's an antihistamine. But it works really well to make you tired, put you to sleep. ADHD medications. Again, risk of dependence, tolerance, withdrawal, risk of abuse. Knowing the different ones, knowing which ones can be crushed and snorted in the bathroom at school. So, I read ADHD is overdiagnosed and to the tune of 300 times its actual occurrence in schools. Every behavioral problem is now ADHD, so let's put them on an ADHD medication. Of course it's going to work, but it's not working for the reason that you want to put them on it. You can't control someone's behaviors, you can't change someone's lifestyle by putting them on a medication. So this is where primary care and behavioral health can work really well together to understand why a person is acting, a child is acting the way, not getting their needs met, right? If anyone was in the last presentation, right, on language. If a child, an adolescent, is not getting their needs met and they're using inappropriate coping skills that are leading someone to say, you have ADHD, let's just put you on some drugs, right? Instead of dealing with the actual underlying social determinants that are causing those issues. Spitera is one of the things that we started to use more of because it's not addictive, but it still works. And then also BP, blood pressure medications can be used in the adult population. So clonidine, we use clonidine in our primary care facility a lot for well, anxiety and hyperactivity. And then we get into the heavy hitters, right? The mood stabilizers, which, well, understand they're actually anticonvulsants, but at different doses they have different effects. It's kind of cool. Lithium, of course, it's a salt. Also, lithium, Russell was just telling me that lithium is neuroprotective, so it helps alleviate the natural breakdown or the atrophy of the brain over time as you age. So basically we should all be on lithium and Zoloft. But I can't prescribe, so see the PA. Oh, but the doctor left, right? So she can't now. Come on. It's the end of the day. I'm trying to lighten it up. And I'm running out of time, so. Antipsychotics, okay, big hitters. A lot of times we get patients that are on antipsychotics for diagnoses that they don't actually have, as my first case study. You know, so we will do our best to work together as a team, and typically titrate people off a lot of these medications when we get them in off the street with them, because we want to get them at baseline, work as a team to see where they really are at. And I mean, we'll check in with them every day. You know, we'll titrate them off a weekend and we'll have them in on a Monday and a Wednesday and a Friday, so then we have that week to see what happens when they come off these medications. Then we'll have them check in and we'll have the nurses call them. You know, I'll run in, hey Michelle, can you call this person? You know, okay, check in on them. Yeah, they're doing great, good. We took them off their meds a month ago and they're fine. Or we took them off their meds and they're starting to get manic. Okay, we need to bring them back in immediately. Or we have a plan with them. So if these things happen, you need to call us. And then, depending on what's happening, you know, we will restart you on some of these meds. But only in that collaborative care environment where everyone has that open door policy can you actually do that kind of work. The private practitioner can't do that with the doctor that's, you know, across town, or the PA that works at Dartmouth, or anyone else for that matter. Oh, and then our favorite, addiction meds. We have a pretty good medicated assisted treatment program at Health First. So, oh, there's Narcan, of course, everyone, Narcan's the big buzz med, so we don't really need to go over that, but there's the three biggies. Actually, there's just two biggies, and one that's just the culmination of two different ones. So Suboxone is basically Narcan and buprenorphine together. So, anyone know what the difference between an agonist and an antagonist is?
What was the question again?
I mean, I know,
Was that a nursery rhyme?
What was the question again?
So an agonist makes something happen, and an
Okay.
antagonist stops something from happening. It's easy as that. And then we have partials, you know, so. Methadone, there was a lot of talk about methadone and some of the other anti-use for alcohol. So all this does is block the processing of alcohol. So like we'll use naltrexone, Vivitrol, for cravings. It works in the reward center. We don't use this as much. People get sick, get really sick. Oh, see here you can test your knowledge, right? You can earn your 1.5 CMEs right now by testing your knowledge and reading this. But you will have a copy of this so you can test your knowledge at home. All right, so that was like a 5-year process, a 4-year process. Everything that we just discussed, I knew none of that when I first walked into the doors at Health First as an intern, none of it. I had to learn it all on my own. There are no schools that teach this, right? You have to learn it on your own. You have to figure it out on your own. You have to, when you're working with providers, you have to really break through those barriers and become the champ, facilitate the socialization, build that understanding and respect, build the trust and rapport. And that's all about education and co-education in a really respectful, collaborative way, right? So I'm not coming in and saying, hey, listen, you got to send your person to me. Like, they don't need to be on those benzos, okay? So, although I did affectionately call one of our doctors Dr. Benzo once, and I'm not sure if he thought it was funny or not, but he humored me, and guess what? He got on board with the benzodiazepine policy, and he started titrating his patients off the benzos, and he was like, yeah, you're probably right. It's just something easy to do. It's easy to do when the patient's right there, and they're freaking out. And they have all these symptoms, and they're panicking to give them some benzodiazepines. So, once that happened, people say breaking down silos, but what's breaking down silos? You can't just break down a silo. That's a process. Silos come down as a process. It's not something you do. It's something that happens when you do all the rest of this stuff. So, one of the best ongoing case studies that I have is a 37-year-old Caucasian female that presented into Health First to her primary care provider. She had been seen in the ED. She had acute alcohol intoxication and alcohol poisoning, and she came to see us about a week after that. She was still in kind of protracted withdrawals, and she was all over the place. She was dysregulated. She was jittery. She was agitated, and the provider was really uncomfortable. And so she just said, hey, Dave, can you come in here? So of course I can. So I went in there and we sat down with this person and I started talking to her and whoosh, she calmed right down and we worked with her for about an hour and that started a relationship that is now, did I put the year up there? I think it's 3 years now. I think she's 3 years sober. Next month, I believe, February or something like that. She never touched a drop of alcohol. But every time I see her, she comes in and checks in with me every month. Not because she has to, because she wants to. She wants to come in. It's kind of her safety blanket. She comes in for one of those 20-minute quick checkups. She comes in, she sits down, she says, hi, I'm doing great. She tells me what she's doing, and she's off. But this was a really tough case because she had some significant mental health issues, which she had been using alcohol for her whole entire life since she was very young and since preteen. And she was extremely bipolar. And when she went in a manic phase, she would stay in a manic phase for months. And she would sometimes wake up in another state in some guy's bed in a drunken stupor and not know how she got there. Like literally 4 or 5 times in the past 5 years before that instance. Oh, 10 minutes. She ended up in another state and then had to figure out how to get home. And she didn't know how she got there. She lost a month of her life because she was drunk and manic the whole time. So we worked with her. It took us 2 years to figure out her medications. And this was another really great instance of collaborative care. We had her on an SSRI. We had her on Zoloft and Depakote, and then it all stopped working. and she was going into these deep depressions, and she was rapid cycling, and we're like, well, she was stable for 6 months, and nothing was working, and so we put her on Abilify, and then that stabilized her for like a week, and then she crashed, and then I'm like, I was talking to the nurse practitioner who was not very schooled in the antipsychotics, and she was very uncomfortable with it. So Russell came in, the gentleman that's going through the psych program, and he talked to her about maybe doing Seroquel. So 2 years after, we finally figured it out. 50 milligrams of Seroquel, 100 milligrams of Zoloft, and she's got a whole new life. She hasn't had a depressive or a manic episode since. But it took 2 providers, well, me and 2 medical providers, 2 years of working with her, calling her. She didn't show up for an appointment, I called her. Like every week. And she's doing great. She's working full-time. She was on disability. She went off disability on her own. She's working full-time. She's got her own place. She's reestablished her relationships with all her adult children that she had lost through this process. So, and if she was here, she would tell you what she tells me every single time she walks in the door. She said, health first saved my life. The NP's name was Stephanie. She goes, you and Stephanie saved my life. If I didn't meet you 2 guys, when I met you 2 guys, I would be drinking and I would be dead. So, I don't know how many slides I have left, because after this episode 2, it doesn't come back. So, I know I have about 6 or 7 minutes left, so I'll kind of wrap it up. So, integrative care, so proximity, open door policy, multidisciplinary teams, multi-provider patient care, warm handoffs, we've talked about like in the hallways, okay? That's not something that we do, that's something, I mean, how do you say it? It's not something we do, it's just who we are. Like warm handoffs is the language of health first in that pod that I work in. Collaborative patient scheduling, we schedule the patients to see me and Russell at the same time. They come in to see, they sit with me and Russell, and we do the behavioral and the medical visit, the medication stuff at the same time. For not just MAT, not just medicated assisted treatment, not just for our Suboxone patients, but for all our patients that are on a serious regime of psychotropic medications that are in counseling for long term. We see them together, to assess them together, so we're on the same page. I've already actually gone through most of this. I'm going to skip that because it takes too much time. So, all departments, all people, every single person. Yes, ma'am?
So, I'm just wondering, you mentioned that you grew a lot over the 6-year process. You started being able. How have you had some practitioners who did not adapt to that collaborative environment? And if so, has that informed how your hiring process works?
Okay, so let me just flip through this. Cultural indoctrination. I'm going to stop at this slide because it's really cool. This is my mental vision of health first, how we operate. I think everyone's going to get a copy of these, but so I talk about the cultural indoctrination. So important that when new people come in, we didn't have that at first, but when new people came in, starting about 3 years ago, we've had a 100% turnover of staff in 3 years. So, like, I'm one of the sole survivors and one of the NPs in the other building. We've been there for like 6 or 7 years. Everyone else is new. Everyone, like the entire staff, practice managers, clinical managers, nurses, MAs, providers, everyone's new. So every time someone came in, you know, Rick was like, hey Dave, why don't you just meet with these people and tell them what you do? I'm like, oh, I'm gonna take it one step further than that. Like, I come in and I say, this is what we do here. And, oh, you have this patient, I'm coming into the room with you. And they're like, what? Right? This is how we do it here. And that started the biggest barrier, the biggest breakthrough barrier, I think, is when we hired this one doctor who had done a little bit of this in the past, but he came in and him and I bonded really well. We became really good friends. And that right there was the real big start of the collaborative care. When the LICSW and the DO started working together with 30 to 40% of all the patients that came in on the doctor's panel. And then when we replaced another nurse practitioner, that was Stephanie was the next one to come in. This is what we do here, Stephanie. Oh, okay, she was right out of school. She thought it was cool, right? She didn't know any different. She was new. And then we hired Russell, and Russell came in and he was like, that's a novel idea. And then of course, Russell and I became really good friends. And we just grew that relationship through friendship and through mutual respect and collaboration. So it was generational as the providers turned over and as I was able to kind of pull them into this model and work them in this model and show them the value and show them successes of the other people at Health First that were, you know, with our patients and having all these successes. It was just like, okay, this is what we do here. This is what we do. This is what we do at Health First. So, I have more slides, but I think I'm going to stop on this because I have, what, 5 minutes left?
Yeah, exactly.
Yep.
So, where's the gentleman? He left. The gentleman that did the presentation earlier before lunch had something similar to this, but you couldn't read it because it was really small. Patients are in the middle, families and patients in the middle, but mine is a little different because he had layers going out, like people are further away. I don't conceptualize it that way. As you can see, my model, everything touches either directly or indirectly patient care. Everything affects patient care, right? The financial team, the billing team, the prescription team, the operations team, the management teams, the coordination team, they all indirectly affect everything that happens. The support staff, right? They affect the operations of the floor. So they affect patient care. Directly, nursing, the medical providers, behavioral health, patient navigators, dietitian, occupational therapy, social workers, and the case managers, directly affected. But as you can see, I made all those arrows intersect because we all affect each other, right? So one of the biggest things about this is that it's self-admittedly, it's a difficult thing to do, but every